Hello, everyone. This is Carol Scott with the National Ombudsman Resource Center, and I am happy to welcome you to the third in the Recovery and Reentry Series Technical Assistance Open Dialogue webinars. Today's conversation is about successful complaint investigation and resolution during COVID-19. We've got some great speakers and some great situations you're going to be hearing about. I want to encourage you to type your questions into the Q&A feature and to use the chat to talk with each other. If you have a situation or a case that you want to shout out about how you worked on it, excuse me, feel free to do that. Please complete the evaluation questionnaire when this webinar is concluded. We really appreciate very much getting feedback on how we can present better training for you. The chat and QA boxes can be found when you hover your cursor at the top of your screen, and you can see the chat and the QA feature there. And we will have plenty of time at the end of the session for questions and answers. First poll question, Katie, if you'll bring this up. During COVID-19, did most of your complaints originate from residents or families? Yeah, that's kind of what I thought. Obviously it was very difficult to reach the residents, but I just wanted to see, and it looks like about 11% staying pretty steady, 11 to 12% from residents and 89% from families. And what that tells me is that you guys did an incredible job of reaching out and finding those family members and starting conversations with them and making sure that your contact information was available to them. So we'll leave that. Yeah, let's, Katie, let's stop the poll. Yeah, 12% from residents and 88% from families. Very, very interesting. Thank you for that. Want to call your attention to the COVID-19 recovery and reentry resources. We do have one called Responding to Complaints, and there's information there for state ombudsman that has management considerations, triage when there's just so many things coming at a program, and tracking facility and systems advocacy. So it might be interesting for those of you that are not the state ombudsman to take a look at this document. And the link is in the PowerPoint, and the PowerPoint was sent out to you guys yesterday, and I'm sure Katie can put a link in the chat for you throughout this if you didn't get it, or if you want to open it up now. There also was a document called Complaint Investigation and Resolution, Complaint Scenarios and Documentation Scripts. And this has some very, what we think were pretty typical complaints that you might have received, and also the information on how you would document that, whether it was who the complainant was, whether or not the complaint was in a nursing facility, whether it was verified or not, whether it was partially or fully resolved to the satisfaction of the resident, and whether or not a referral was made. So, and these were all part of your homework. So I'm actually hoping that you're going, yes, Carol, we've seen all of this. There was also the NORS FAQ, frequently asked questions, that talked about complaint coding, talking about what happens when the facility did not return your call, or staff not answering the phone, and how you would mark that complaint down. And again, the links to the website to where these documents are also listed on this page. And the Administration for Community Living also had a FAQ on complaint processing. You can click on the link at the bottom of this slide, or and see all of the information that ACL provided. That I can see that most of your well, all of your state ombudsmen are very familiar with this page, but the rest of you might want to just take a look and see the kind of information and guidance that ACL provided. There are also some other resources that the Ombudsman Resource Center has on complaint processing. And these are 3 of them, all dealing with, oops, shoot, what happened? All dealing with, all dealing with abuse and neglect. And so making sure that you understand the role that the Ombudsman program plays in responding to allegations, and then the part of the long-term care Ombudsman rule regarding supporting person-centered advocacy and complaint investigation webinar that was done previously. Poll question number 2, Katie, if you can put this one out. If you have resumed in-person visitation, are you receiving less, the same, or more complaints than you did before COVID-19? And if you haven't resumed in-person visits, you've got a place there to indicate that. And I'll tell you what my hypothesis here is that it's going to be less, but I can see that I was wrong. Isn't that interesting? My thought has been that residents are going to just be so excited to see you that you're going to be spending time just listening to them, and that they're going to be a little bit hesitant to speak out, maybe during your first visit. But I'm glad to see that you guys are having those conversations and finding out that a lot of you are seeing more complaints than you did before. Katie, you can close this one. So the same is about 35%, more 31%, 19% of you are seeing less. And I think that's, like I said, I think that's very normal that people are going to take some time to be able to open up again and kind of feel comfortable in making a complaint. You can stop sharing this. Thank you. And those of you who haven't resumed in-person visits, which is 15% of you, I hope to, the next time we do a webinar like this and we ask the question, I'm hoping that you guys are also able to be back in your facilities. And for those of you that are raising your hands, I don't have the ability to respond. You'll need to be typing in your questions in either the Q&A or making your comment in the chat. Just a reminder that World Elder Abuse Awareness Day is coming up June 15th. And we would be at the Resource Center very interested if you would send us a brief example of a case that you have worked regarding abuse, neglect, or exploitation. And those can be sent to the Ombuds Center at theconsumervoice.org. Doesn't have to be long, just, you know, just a brief example of the kind of case that you're seeing. If you want to say how it ended up, that's fine. But we could get those by the 1st of January or June, 1st of June, so next Tuesday. That would be wonderful. And again, it goes to Ombuds Center at theconsumervoice.org. Our speakers today are Amanda Grooms. She is with the Kentucky program at Buffalo Trace Area Development. I covered it up. District in Maysville, Kentucky. Tika Moten is the state ombudsman in Tennessee, and she has stepped in and done a wonderful job in the short amount of time she has been the state ombudsman. Kim Boyd is the district ombudsman in Northwest Tennessee. Melinda Lunde is the ombudsman in Middle Tennessee. Thomas Kaler is in, gosh darn, I can't see what part of this, it says east, so I don't know if that's northeast, southeast, because it's covered up. So Thomas will have to tell us what part of Tennessee he's in. And then Zeb Samuels is in the District 9 program, which in Memphis. I did know that. So the western part of the state. So I turn it over at this point to Amanda, and we will hear some wonderful things that she has been working on. Thanks, Amanda.
Thank you, Carol. It is my pleasure to be with you all this afternoon, and just my pleasure to be able to be part of this wonderful webinar series that's going on. First, I would like to take a minute to describe how our program is laid out in the state. Our state ombudsman is Sherry Culp. We have two regional ombudsmen, Mark Burris and Jody Holsquall. They operate out of the Nursing Home Ombudsman Agency in Lexington. Our state is divided into 15 districts. Each district has their own local program. Most of our programs are housed in the area development district. I will say that I cover the smallest district in the state. I cover the Buffalo Trace region. I have 5 nursing facilities and have approximately 400 residents in those facilities. It's my absolute privilege to serve them. Statewide, we have 312 nursing facilities with approximately 28,000 residents. We have 203 personal care and family care homes with approximately 8,000 residents. We also have 37 additional certified ombudsmen across the state, 131 volunteers, which we refer to as friendly visitors. And we also have 76 who serve on advisory councils and volunteer with our program in that way. We'll go to the next slide. The case that I'm going to share with you all today really stands out to me as I look back over the past year. It stands out for multiple reasons. Some background information. This client was a 62-year-old male with lung cancer that had metastasized eventually to his brain. He underwent a craniotomy on January 5th of this year and was transferred to a nursing home 2.5 hours away on January 26th. He was transferred to a very remote, very rural area in my district. He never married, never had children. Both parents had passed away. His sister was his POA, and she had been appointed his POA prior to his craniotomy. The resident truly believed that she was his best advocate, and when the time came that he was no longer able to make decisions on his own, that she would be the best person to fill in for him. The sister is actually the one that reached out to me first, and kind of as our poll reflected earlier on, during the pandemic, during COVID, we mostly heard from family members. This POA found my contact information on our state's website. She sent me a very, very lengthy email one Saturday afternoon, had several complaints, and some of the main complaints that she had The resident had no care plan meeting, or at least no formal care plan meeting. His advanced directives had been changed from a DNR to a full code when he arrived at the facility. They were not honoring the POA document. He had multiple canceled appointments that the facility had canceled. And when he was transported to doctor's appointments, he was continually late to those appointments due to poor time management on behalf of the facility. He had reoccurring falls. Nothing was being put into place to prevent those or to address that. The sister was denied compassionate care visits, and there was poor communication all the way around from the facility staff. The sister, power of attorney, completely believed that the facility was taking advantage of her brother while in a very compromised state. So I got back with the sister right away, but I knew that my first thing I needed to do was reach out to the resident and talk to him and kind of get some more information. So the quickest way to do that was to give him a phone call. And so I called the resident, and after kind of being rerouted from different nurses stations to the front office and around the facility, I finally was able to speak with him. I can't say that it was in private. I'm not sure if facility staff were there or not. And I know as ombudsman this past year, that's been a kind of a hurdle that we've run into a lot. But the conversation that I had with him, I could tell that he was very confused. He sounded weak over the phone. He really wasn't sure where he was. He was kind of all over the place with his thoughts. He went from, this is the best place I've ever been, although he didn't know where he was, to get me out of here right now. So it was pretty obvious to me that I needed to do a face-to-face visit to lay my eyes on him and just get a better picture. I think we as ombudsmen, we have really risen to the occasion this past year, and we've been creative and clever with ways that we have reached out to residents and communicated with them. But I truly, truly believe that our greatest work is done at bedsides. And so I knew that I needed to go see him. I followed all policies that were in place regarding visitation. I respected those. They performed a rapid test on me. I had to wait 15 minutes when I got there. Results came back negative. I was wearing a surgical mask and a face shield. They checked my temperature. I completed a survey, and then I was able to meet with him. I was able to meet with him in his room. This resident had a private room. I was led in there by the administrator and the director of nursing. They wanted to introduce me to this gentleman. And we get in there, and it's pretty obvious to me right off the bat that not many people, I think, had really taken the time to talk to this individual. Although he had been there for, over a month, it was obvious that he was kind of used to being interrogated or badgered with a lot of questions and multiple staff kind of in his face. And, I quickly asked the administrator and DON if I could, visit with him privately, and they did. They respected that. And so I was able to kind of talk with him a little bit more. It was important. I wanted him to know that I wasn't kind of like everyone else that had been in the room. I wasn't there to badger him, to push a treatment or aggressive treatment on him, to talk about end of life care or anything like that. I was simply there to get to know him better. I use a lot of the objects in the room, my surroundings, to kind of guide and facilitate my conversations. I saw pictures at his bedside where he was holding a fish. I asked him to describe, that trip. Where was he? He had a University of Kentucky shirt on, so we started talking about basketball pretty quickly. He started to open up more and more. Early on in the conversation, he would kind of make comments like, yeah, whatever you say, or it's up to you. I kept reiterating, I'm not here to force you into any decision. I'm just here to get to know you. At one point, he broke down. He started crying, and I asked him kind of what's going through your head. And he kept saying, I want to go in peace. I want to go in peace. We weren't talking about his diagnosis. We weren't talking about end of life or anything like that. He was really telling me that he knew that the days ahead of him were a lot less than the days behind him. He knew how sick he was. He mentioned that he didn't know what he was signing. He didn't know where he was. He was alert, but he just was not oriented due to diagnosis, due to the recent surgery. He was not able, I think, to make a lot of the decisions that the facility had pushed on him, and what he had consented to. I don't think that he was fully aware of what he had consented to. We talked about his sister, and you could tell that really kind of touched him, and he cried more, and he just kept repeating, she knows me, she knows me, indicating to me, I want her to be more involved. I had appointed her as POA for a reason. When the time comes that she needs to step in, I want her to do so, and that time is now. I visited with him, over an hour, really just kind of just trying to get to know him better. He gave me consent to speak with his sister. He really wanted the sister more involved, wanted the facility to talk to the sister more often. He really wanted to be left alone. He wanted the facility to leave him alone from the constant kind of questioning and everything else. I was continually going back and forth with the sister after our visit. We discussed the need for a compassionate care visit. And at first, the facility was very resistant towards that. I wouldn't say that they denied the compassionate care visit, but they didn't see the need for one. The facility really wanted to focus on end of life and weight loss as the only situations that would warrant such visit. At the time, our guidance actually reads that end of life visitation would warrant, yes, but other types of compassionate care include, but not limited to, that's a very important statement. A resident who is living with family before recently moving to the long-term care facility and is struggling with the change in environment and lack of physical family support, is grieving after a friend or family member recently died, needs cueing and encouragement with eating or drinking, used to talk and interact with others, is experiencing emotional distress, seldom speaking or crying more frequently when the resident rarely did that previously, is unable to receive a COVID-19 vaccination. So I sat down with the facility, I presented them with the guidance, we read through the guidance, and they came around to the compassionate care visit. I explained to them, we went over, the emotional distress that this gentleman is under. He was uprooted, relocated from his home. He had not seen his sister in over a month, had not seen anyone in over a month. And so the facility did agree for a compassionate care visit. The sister visited with her brother at the facility, and then she was also able to accompany him to a doctor's appointment as well. That visit did not go well. They did another scan and the brain tumor had grown exponentially. At that point, the resident, he refused any type of treatment. He did not want to be sent out of the facility again. Again, we were in a very rural area, and so these doctor's appointments were 60 minutes away, 60 minutes of back road as well. And this resident was just way too sick to be going through this, and he was making these 60-minute trips. Sometimes the facility was dragging him 3 appointments a week. We had a care conference after this appointment. The sister really, I kept pushing for the care conference. The sister agreed. The facility agreed to meet with us and allow us to come in. The resident was invited. He declined. He did not feel up to it. The POA and I, we met with the administrator, the social worker, the director of nursing, and also members of the facility's therapy department, because up until that morning, he was still receiving skilled therapy. The power of attorney and I, we really, explained kind of where the resident is coming from. I really went into detail with them over how my visit went with him and kind of what the resident shared with me. And I said it was just very obvious to me that, no one was actually taking the time to listen to him. People were in and out of the room all day long, but no one was actually listening to what he had to say. We were able to resolve a few things, such as the bed rails were ordered for his bed, and that was kind of a fight too with the facility. They were very resistant that they didn't want the bed rails because they would be a restraint. Well, if they're used properly and ordered by a physician, they would not be considered a restraint. So we talked through that and worked through that. That meeting, that care conference, was a real turning point in this case, because the facility finally at that point kind of let up on the resident, started respecting his wishes more, and let the power of attorney be more involved. Again, that is what the resident wanted. He was eventually transferred to a hospice inpatient center. And just to give you a little a time frame, our meeting was on March 2nd. He was transferred to a hospice inpatient center on March 9th, and then he passed on March 12th. We got him to a place that he wanted to be. No doubt in my mind that his final days were peaceful. His pain was managed, and his sister was by his side, allowed to be by his side. So that's just that. It's a case that stands out to me. This actually was the first time that I re-entered a facility, but I certainly knew that I kind of had to put all of my hesitation and reservations to the side. And I'm so glad that I did, because stepping back in, I realized how important our listening ears are and how important our voice is, and truly how much those residents need their advocate. On the next slide, our state ombudsman asked us a couple months ago, district ombudsman, to just share how COVID has impacted our work and how we handle our cases. And so these were 2 statements that were submitted. Unfortunately, during COVID, our work has increased, and it has taken longer to resolve concerns or respond to callers. No longer are we able to handle group concerns within a 2-hour visit. Now we are faced with individual calls being placed to residents, family members, and staff. We continue to experience barriers with antiquated phone systems that sometimes take about half hour to reach someone. It can sometimes take several days to work on one issue, which previously could have been resolved in a matter of minutes. And in this case that I shared with you, it was over a month that I worked on all of that. Someone else shared case resolution in a timely manner. Resolution requires 3 times the amount of time because having to contact all parties via phone or email. Our roles have changed. Our roles have not changed as ombudsman, but this past year we definitely have realized that we have had to navigate those roles a little differently. And then on the next slide is my contact information. If anyone would like to reach out or have any questions.
Thank you so much, Amanda. Great information, great case, and I'm sure that resident and his sister are very thankful for your involvement. At this time, I'm going to turn it over to, don't look at the camera because Tika's getting all prettied up. Oh, she's gone. I'm sorry, I didn't mean to embarrass you. So I'm going to turn things over to Tika and the folks from Tennessee. So unmute yourself, guys, and you're ready to go.
Well, good morning. Good morning. Thank you for having us, Carol, and the rest of the NORC team. I'm excited to give this presentation. I promise I'm only going to talk the first few slides, and then I'm going to turn it over to the wonderful team who has helped us throughout COVID. Next slide, please. Rather, our boots on the ground. So Tennessee, the volunteer state, goes from left to right. We're a pretty long state. We have 3 grand regions, and that's important because that's kind of how we deal in our interactions with our Department of Health. They're broken down into 3 grand regions. Memphis, today you'll hear from someone, the district ombudsman from Memphis, Nashville, Knoxville, and then from a place on top of Jackson in Northwest Tennessee. Next slide, please. So a little bit about the way that our program is organized. And as I listened to Kentucky, I realized we are a very, very volunteer-driven program. We're decentralized. Our state office is located in the capital of Nashville, within our state unit on aging, also known as TCAD, or the Tennessee Commission on Aging and Disability. We are divided up into our 9 AAAD districts. 5 of the programs, 5 of our district long-term care ombudsman programs are contracted out through AAADs. 4 of them are contracted out through nonprofit agencies, 2 of which are directly contracted with those agencies. And I just put a note there. Sometimes I hear folks refer to ombudsmen that are boots on the ground as locals. We call them district long-term care ombudsmen, as we have 9 distinct district ombudsmen in those areas. And we have 1 lone state employee, which is me. So there are no regional or extra ombudsmen. We run a pretty tight crew on a shoestring budget. Next slide. And that's a model of it for the most part. Next slide. So by the numbers, we have 16 full-time staff on our program, 1 part-time staff member, and a little over 200 volunteers for our program statewide. Of course, that number needs some adjusting for the COVID turnover and for those who get to participate with our reentry training. However, we bolster almost up to 200 volunteers at all times, which are the lifeblood of this program. As for the count of facilities throughout the state, we have 315 skilled nursing facilities. We have 415 assisted care living facilities and over 100 residential homes for the aged. In total, we serve some 61,000 residents in licensed care facilities throughout the state of Tennessee as of our OAP submission to ACL. Next slide, please. So I want to put it a little bit in context for you guys before I turn it over to the wonderful district ombudsmen who have helped us make it through COVID. First part is that I took this job in January. We started meeting weekly in April due to COVID. We took a monthly meeting, we pushed it back, and then we continued to meet weekly through Zoom, through conference calls, through Teams, and what have you, as our needs change for security and that sort of thing. Another thing I'll say is that we tried to keep our VORs, or our volunteer ombudsman representatives, engaged through bi-monthly meetings where we talked about the numbers of COVID, where we talked about telephone reassurance and opportunities to help us. And earlier on, we encouraged them to help us make masks. Another piece of information that's vital is that QSO 2119 that came out May 11th has made for a very interesting twist in this state, depending upon the region, because we have a number of people who've decided to remain unvaccinated. Another piece of information that makes Tennessee unique, and I wanted you guys to have this in terms of our context, is that Adult Protective Services, as far as ours is concerned, because I've seen it in the chat where someone says we do not work abuse cases, APS follows up. Well, in Tennessee, we are one of the only states, I believe we're the only state, our state funds do not go toward APS, only the federal funds. So a lot of the cases that we get from them are actually screened out. Another piece of important information is that we passed immunity legislation on COVID-19 within weeks of the first wave of COVID. And last but not least, one of our safety net facilities, which was located in land owned in Nashville, was where we oftentimes send our compassionate release or inmates that were coming out, as well as HIV patients. And so that was a pretty tough blow during COVID for us. And I want to update our state ombudsman. I know we've been talking and kind of keeping pace with who's going back in and who's not. Well, we learned the day after QSO 2119 came out, our governor announced that we will be returning for annual surveys as of June 1st. And so it will make for an interesting week next week. As of now, they are only going in for infection control surveys and for IJs. I'm sure you'll hear a little bit about that today as we have begun going back in and have seen some interesting things to say the least. Next slide. And so here you have the state of Tennessee, how we have it broken up. And we number from right to left. But the reason why you saw East Tennessee is because East Tennessee is its own region. That first one is First Tennessee. Those are our Tri-City areas. That's where Bristol's racetrack is located, so on and so forth. Area 3 more so has Chattanooga. The fourth area is known as Upper Cumberland or our Plateau. South Central is number 6. Nashville, Clarksville, Murfreesboro, some of our bigger cities are in that District 5 area. District 8 is our southwest area of Tennessee. Northwest is number 7, and number 9 is Zev. Today you'll hear from District Ombudsman from District 2, 5, 7, and 9. Without further ado, next slide. I'm going to turn it over to Thomas Collier, who is our District Ombudsman for the 2nd District.
Thank you very much, Tika, and to everyone. Thank you for the opportunity to present to the group. So I think you can see and literally could hear from Amanda's presentation that the quality of care issues in long-term care and our reentry into the facilities are critical. Frankly, I think she just gave my presentation, so not that she was trying to steal my thunder or anything like that, but I listened intently and was very moved by the work and relate to it on so many different levels. So I'm going to try to be brief. I just want to touch on some of the bullet points real quickly. The March 2020 cutoff from access was just so abrupt. None of us really knew what to expect or how long it would affect our access. And as it drug on, let's just say it interfered completely with the process of interacting with residents. So, and particularly impacted access to our investigations into complaints. So obviously that, and I'll echo just what Amanda said, because I had it in my own presentation, there will never be a substitute for being inside a nursing facility for those in-person visits, that face-to-face chat. Because it gives us the opportunity to use all our senses, not just our eyes, but it really has a significant impact on our perception. So much of what happens in a resident is body language, which she also indicated. So it's just important to say that the inability to access facilities really complicated things. So it did take time for facilities to obtain and utilize equipment. She touched on the fact that it increases the amount of time that we're having to take to investigate cases, to work with residents. And so I'm just going to echo that without really going into it very much. there was money provided. Some of the facilities were a little slow to take that up. And in many cases, I actually was talking with residents and doing virtual visits on private or personal cell phones that the staff would provide. So I want to touch a little bit about the workplace shortages because particularly in rural areas, honestly, nursing facilities in general have had difficulty recruiting, training, and retaining staff long before COVID. So in Tennessee, we have very, I think that our requirements for staffing are low, and honestly, that obviously impacts quality of care before COVID ever hit. So only exacerbated the problem when it did hit. Nursing facilities in metropolitan areas have a broader, or at least a prospective pool of applicants than to draw on than necessarily rural facilities do. Rural facilities in my district, at least, are more part of the community, and they have an allegiance of sorts to, and so it was staff levels remained typically fairly high for most of the initial time that when COVID hit, but with the number of positive staff tests, stimulus and unemployment checks, motivation to work, and the number of staff declined, as did the quality of care. So we maybe weren't as initially aware of the issues as we are today, obviously, but the reality and gravity of the decline of quality of care has become very clear. So we're absolutely needed. Again, I'm just going back to my counterpart, Ms. Grooms, and her presentation. So yes, we're seeing, when we're re-entering, we're going to start seeing an increase in the number of residents who've had weight loss, pressure sores, dental problems, fingers and toenails not clipped, feeding assistance not provided, call lights, the dehydration, UTIs, just a plethora of maladies that these residents are being left, that are in many cases just have been left unattended. So how we learned about this was primarily through families. As I said, the quality of care wasn't immediate, but it only took a few short months really to see the writing on the wall. So families have been our conduit of information. They really weren't able to see very much other than through window visits, but frankly, they were intuitive about what they were seeing and were very vocal about it. So now some residents certainly retained the wherewithal to contact us and describe the decline in quality of care, but albeit with some limited success. But and then some residents were being seen by contracted sitters who shared their observations with family, again, relating them to the Ombudsman. And at times, hospice was another resource for information. And nursing facility staff really became ultimately more disenfranchised simply because the long hours, increasing number of residents they had to serve, and began contacting the Ombudsman on behalf of residents. A recent development, at least in my district, and in two cases in the last few days, were contract staff who came into a facility and were really despondent over the conditions in the facility and immediately filed complaints with the Department of Health and/or notified me at length with a long document. So I think you know about immediate jeopardy, so I don't really want to get into that part of it right now. But as far as empowering our staff, or residents, about compassionate care visits, CMS didn't exactly detail what it was. So only that there was 4 examples. And honestly, that was something that we could take advantage of. It lent itself to a lot of flexibility, and why I tried to do all I could to keep up an independent effort of logging all facilities that were allowing compassionate care visits or those that were problematic. I have 2 part-time staff that were very efficient in that respect, and that certainly helped us. We shared all the CMS guidelines to educate residents and families. I contacted admins and directors of nursing via conference calls, or made direct advocacy a priority where they were restricting visits, or how strict they were in interpreting the guidelines. So, but we really were fortunate in most respects. Compassionate care wasn't so much an issue in Tennessee or in East Tennessee. We are the volunteer state. People are very close to their families. And in most cases in East Tennessee, now the experience across the state I know was different, but we did deal with the compassionate care issue or compassionate care visit issues rather effectively, fortunately. So, and Tika alluded to our Department of Health listed state mandated guidance regarding long-term care visitation in deference to the CMS guidelines. Those things are fluid as well, but the revised expanded visitation really in essence just laid bare the quality of care issues that we all suspected. It's going to take a considerable amount of time to get back to pre-COVID levels, but it's my hope that the whole experience will result in new legislation and or policies that will help residents in long-term care facilities avoid these future epidemic situations. And so how did I handle complaints of continued low quality of care? I think I'll wrap up again and refer to Ms. Grooms, because thank you. You really did provide an excellent synopsis of what it takes to go in and deal with a resident's issue. As far as communication, well, communication is key. Throughout COVID, I just communicated via virtual visits and or electronic devices, phones, including TDD. I have several deaf residents that I communicated with to get their consent, or at least get an impression of their cognitive ability, level of care needs, and quality of care issues. So, and as facilities have begun to reopen and we've started re-entering, I've been making some in-person visits. Each facility does have some unique policies in terms of where visits may take place and for how long, but I've tried to be accommodating to that, but I've made it clear that the Ombudsman could not be restricted in terms of access. So I just developed a really strong rapport with the admins, directors of nursing, social services, general nursing, and they've been my primary conduit for documentary evidence. I request face sheets, H&Ps, progress nursing notes, care plans. Those give me a direction in how, and they may influence the course of my investigation. So again, well, all this is with consent. I talked with the POA, representative of the residents representative, family members as much as I can about the complaint, since they're often in communication. I'm careful, as we all are, to understand families may embellish on a narrative, but I make it clear that my role is not their advocates, but the role is the advocate for the resident, and that the residents direct every part of it to the extent possible. So I do reach out to hospitals on occasion, although they don't necessarily have to provide me with information. And and I reach out to the state surveyors who have had access to the nursing facilities and have been willing to look out or look in on a resident's complaints that weren't necessarily part of the Department of Health complaint.
Thomas, thank you. We need
I need to wrap up. Thank you for letting me know. And again, thank you for the opportunity to speak.
Absolutely. Appreciate your story. Kim.
She's muted.
Kim, you are muted.
Hi, sorry about that. Yeah. When we started with the COVID issue back in 2020, a lot of the issues we were dealing with in the Northwest dealt with some of the discrepancies in the billing and the, I guess you could kind of say price gouging and fair housing. A lot of those issues were resolved with talking with the families and the facilities, having them to look at their contracts. In my district, legal aid was a big help in helping with fair housing and getting those individuals the assistance that they needed, and to make sure that the facilities were not price gouging, and they were doing fair pricing and not overcharging those residents in those facilities. Also, we had a lot of issues where the corporations that own facilities were moving residents from COVID facilities to anti-COVID facilities. And sometimes those residents and families were not being notified of those movements. With that, we spoke with the facilities, and reiterated that they had a duty to notify these families as well as these residents of the move, and reassured these residents and their families that they would be returning to the facilities with their property, of course, when they were no longer at COVID risk, or those facilities were under the threshold in the COVID within their community or what have you. So a lot of the times, it's really hard in very rural districts because we don't have that city facility count or those resources that we might have in the larger facilities. But overall, in this very rural area on the Northwest Tennessee end, where we're near the Kentucky, Illinois, Missouri line, we were able to resolve a lot of those issues fairly quickly and fairly pleasing to some of those families and residents. We had a facility where there was an issue with an ambulance service not telling, or the ambulance service knew the person was supposed to be going to the COVID facility, but the family did not have an idea and the resident did not have an idea. But once we were able to speak with them and speak with the family, we also got the Department of Health involved. That issue was resolved, and that was no longer a problem in the district. There were concerns where families reached out to us regarding the stimulus monies that the residents received, and we explained to those families about the money that they had and how they were able to spend that over a year, how they were able to use those monies to pay for things that they maybe needed or wanted. If there were a risk of financial exploitation regarding if the person had a representative payee or POA or any of those things, those situations were referred to Adult Protective Services if those were involving governmental funds. And some of our local law enforcements, as well as district attorney agencies, are very instrumental in prosecuting and investigating those cases, especially in the Gibson County area. That DA, the district attorney, has been very, very instrumental in helping with those cases. Another thing that we dealt with was I guess the biggest thing was the financial exploitation in regarding those family members. But again, in some counties, once we spoke to those family members, they were very instrumental in working with us. So overall, this has been a very difficult and trying time regarding the fair housing, the price gouging, the financial exploitation, the movement of the residents. That's hard on anyone, but we were able to resolve most, if not all, of those situations in this area. And now I believe I'm passing it on to Zeb for Memphis-Shelby County.
Melinda, are you next?
I believe I was, but you can go ahead, Zeb. That's
My
fine.
follow-up is after yours.
Okay. Well, while we're getting pictures up on the screen, My name is Melinda Lundy. I am one of 3 district long-term care ombudsmen serving the Middle Tennessee area. We have 13 counties that we serve, and we have the potential to serve 16,000 residents in 183 facilities in our 13 counties. We have a core VOR staff of 28 volunteers. And prior to COVID, that was 35 volunteers that we had on a consistent basis. We're hoping that that core group will grow larger. So one thing I will tell you that you already know is, the term ombudsman is not that widely known, definitely not pronounced well. And most of our residents or family members really aren't sure what an ombudsman is. So I have the privilege, along with the people that serve with me, to tell others about the ombudsman program, what it entails, and how we might be able to advocate for resident rights for them. Since we've been asked to talk a little bit about things that our program has done during COVID in regarding complaints and how to resolve them, one of the things that we've been able to do is, at the start of COVID, prior to the lockdowns of facilities, which would have put us back in the February, March area of 2020. One of the people that I had helped for probably a good couple of years since I've been in the program off and on, they were very familiar with us. They kept my card, kept brochures that we passed out. We get a lot of complaints from people that say, hey, 3 years ago, you helped me with this, or last year you helped me with this. So I did get a call, a text, and an email all in the same day, all in the scope of with a few minutes. The person was telling me there's a nursing home that my loved one is at. And we believe that this COVID stuff, at the time, nobody really had a grasp of what COVID entailed, but they believed that COVID was widespread in the facility and that the facility wasn't doing what they needed to do to mitigate the COVID. So they said, can you please help us? And I said, absolutely. I'll see what I can do to help you. We discovered that there was an outbreak in the facility. Did let the Tennessee Department of Health know about it, and it just snowballed after that. Once they got involved, then we started getting regulations for reporting. There were new regulations for infectious control. This turned out to be one of the biggest outbreaks, if not the biggest, in the state of Tennessee. Unfortunately, I did lose a lot of residents to that, but we were able to help a lot more by actually coordinating efforts with the Department of Health to get them the information that they needed to protect those residents. We, at the start of COVID, once there were lockdowns, we did get a lot of information sent to us by other residents, families, staff, people that had concerns about their particular facility and COVID outbreaks there. We were able to let the Department of Health know. They set up a hotline for the ombudsman and others to let them know on a direct number what we were encountering. And we pulled our efforts to ensure that residents were safe, that infectious control was being practiced in our facilities. If a facility had problems with PPE, they were giving us a call asking us, where can we get PPE so that we can keep our residents safe and we can be safe. Some of the issues that we dealt with coming throughout the whole COVID process were more than just learning that there was COVID in a facility. We dealt with pressure ulcers, billing. We dealt with all sorts of patient dumping, involuntary discharges, life-saving treatment like dialysis. And one of the complaints that I wanted to talk about today involved lack of dialysis for a resident. I received a phone call from the resident's daughter. She was frantic. She had no idea what the Ombudsman program was, but she said, if you can help me, I will take that help. And I said, well, just tell me what's going on. She told me about her mom, who she believed may have a pressure ulcer in the facility. Her mom had gone into a short-term skilled rehab to recover from a minor surgery, but while there was supposed to be receiving dialysis treatments and being taken out of the facility. The facility was not providing the transportation to the dialysis appointments. Her mom had missed quite a number of dialysis appointments, and she was concerned because her mother was telling her she felt like she had a pressure ulcer. I was fortunate enough to be able to have a cell phone number for this resident. Her daughter provided it. I was able to call the resident directly, and after a couple of attempts, made contact with her within a couple of hours of receiving that phone call. It was such a blessing that I was able to make contact immediately, because the resident, in talking to me, I could hear she was in pain. She was moaning and she was hurting. And I asked her, I said, tell me what's going on with you. Explain to me how you would like for me to help you. And she said, I'm hurting and they won't let me leave. They won't let me go to the hospital, and I've missed dialysis for 3 days now. So as an ombudsman, I was able, with her permission, to advocate for her, and to, it took 4 different staff members and just really digging in and plugging in to explain that the resident had the right to be sent out, and that this was actually causing her pain and could be potentially fatal to her. So we were able to get the resident sent out to a hospital to get treatment she needed. While there, it was confirmed that she did have a pressure ulcer, and it was probably a stage 3 at that point. The family elected for her to go back to that short-term skilled rehab to finish out her rehab stay. But while she was there, a couple of days later, the transportation issue came up again. The resident was not making the dialysis appointments, and the pressure ulcer had turned into a stage 4. By the time we were able to get the resident back to the hospital, sepsis had already set in. Unfortunately, that resident family had to make the choice to put her in a hospice and not to send her back to the facility, where she subsequently died. But the family was extremely grateful for the Ombudsman program's involvement, and at least getting their mother to the hospital so that she could be treated, so that she could be seen. And we were able, with the family, to provide information to the Department of Health so that they could follow up to see if any regulations or laws had been broken in regard to how the facility was not transporting the resident to dialysis or treating the pressure ulcer. So we have dealt with, unfortunately, some sad situations, and in other cases, some really good situations. We've been able to obtain visits for resident family members over the Easter holiday, when there was no CMS guidance on family members being able to remove the residents from the facility for Easter visits. We've had some bright spots. We've been able to really advocate for compassionate care and for just visitation issues. Throughout COVID, all of the ombudsmen in my district, we have been a shoulder to cry on, a person to vent to for families and residents. And we've also just advocated tirelessly for compassionate care visits, and for just ensuring that residents are going to be able to have family there if they are at end of life. If they are declining in health, if they need that compassionate care. So we have worked tirelessly across the board on every issue that's come our way. Our phones have not stopped ringing, and we are so appreciative of the families and the residents that we work with and work for, passing our information along, letting people know who we are. And I'm excited because I did get to go back into a facility on Monday to see some of my nursing home residents. There's nothing like seeing your residents in person and just letting them know, yes, I'm still here. I'm still available for you. I've passed out my number more times than I can count because my residents have said over the last year, we've been spotty being able to get out of our rooms and we haven't been able to get to the poster. We've lost your information. So we're distributing information across the board. We're going back into facilities and we're just really excited to be back in in-person capacity, getting to help our residents advocate for their rights, their quality of care, and their quality of life. And now I'll pass it to Zev, who is in the Memphis area.
Thank you, Melinda.
Sure.
Recovery and reentry. What have we been through? So Thomas, Kim, and Melinda have described unique challenges of COVID issues in our state, in Tennessee. So many of you have also seen rampant cases of sick staff and of ongoing staff shortages, triaging care, resources, long-term beds, explosive outbreaks of COVID in facilities and in communities, systemic breakdowns in visitation and in communication, waivers temporarily restricting residents' rights, cohorting of residents sometimes miles away from loved ones, and challenges with economic stimulus checks arriving where? Maybe into the residents' hands or into their accounts. There have been many other challenges as well. My district covers 4 counties and includes the city of Memphis. The area is known as the Mid-South. Our district is mostly urban and is largely poor. Many of the population do not have access to quality medical care. Food insecurity is rampant. The residents in long-term care facilities in the Mid-South need an advocate's voice to secure safe, appropriate, and timely care. They need an advocate's voice to protect their dignity and their general well-being. What happens, though, when the hospitals fill up, their census reaching over 94%? Hospitals have to discharge patients, but where do they go? So for many patients who are too fragile to go home, the answer is rehab. But then skilled beds and long-term care beds begin to fill up. Then what? I have heard some nursing home staff say, maybe some of the current residents don't really need a subacute level of care, or do they? Ombudsmen haven't had physical access to residents or facilities, perhaps until recently, who then is available to prevent facilities from making improper, involuntary discharges? What keeps facilities from dumping residents on emergency departments or at acute care or behavioral health hospitals? I'm not presenting cases, nor is my purpose here to identify facilities or specific circumstances in which these issues were observed. Rather, I am drawing attention to a tremendous burden, an ongoing burden on the lives and on the well-being of long-term care residents. We are now in the critical position of identifying these challenges. We must now learn from them. Next slide, please. Let me tell you about our mayor, our county mayor, Shelby County Mayor Lee Harris. Mayor Harris is the mayor, of course, of Shelby County. He saw elders in his county ravaged by COVID. Nursing home and assisted living residents were particularly hard hit. He asked local long-term care ombudsman to meet with him and with some of his staff. Afterwards, he wrote an open letter to the governor. The letter is on this slide and says in part, in your next executive order, I would ask that you please consider creating a process for safe live visits by court-ordered public guardians. Public guardians? What's the purpose of that? Public guardians are often directly responsible for making critical decisions for vulnerable, elderly, or disabled adults. He also asked for visits by investigators from Adult Protective Services and by first responders, particularly when they're on a call. APS investigators have been blocked from having direct contact with residents of long-term care facilities. And it's hard to imagine that fire departments, ambulances, or law enforcement personnel would be delayed by a facility when responding to a call. Mayor Harris taught us that ombudsmen can have a vital role in local advocacy. Next slide, please. And the next slide, please. Regulations, communication, medical records. There's no doubt about it. COVID-19 has been a hit in the gut for many of us, but we did not lose this fight. Communication is our key. Never underestimate what you can accomplish by communicating. Hear residents and their families. What are they saying? What are the facts? Who is responsible for enforcing the codes? Who has the authority and the ability to represent the residents and their rights? How do we build bridges with those in need and with those who can make a difference? And that includes facilities. Tennessee Code includes the standards of care for nursing homes, assisted living facilities, and other systems. The regulations embodied in the standards define terms as they are meant to be understood and applied. The standards speak of resident rights. The state of Tennessee does not identify every right of long-term care residents, but it sure does offer a process of understanding what is a right and what's not. Did you know that in Tennessee, visitors do not have a right to visit a long-term care resident? Rather, it's the resident who has the right to receive visitors. This is one concept in standards of care. I have no doubt that other states have regulations and documents which delineate rules for the care of residents. The Tennessee Healthcare Association is a professional organization made up of long-term care providers. Our ombudsman program is very fortunate to have a strong working relationship with the THCA. Remember that communication is the key. It can take many forms and always comes with opportunities. I want to end with a saying that has gotten me through the worst of this pandemic. Never, ever give up on a person. This is true for anyone. However, most importantly, never give up on yourself. Next slide, please. Questions?
Have Tika, Thomas, Melinda, Kim, Amity, Amanda. Thank you, thank you, thank you. Tika, did you have something you wanted to say?
I think it stands for every state ombudsman when I say thank you to our district folks, thank you to our locals, thank you to the boots on the ground. You took a fast talking millennial over the course of a few months and taught me how to slow down and to lead with compassion and all type of skills that I didn't have. And so COVID kicked our butts at sometimes, but thank you guys. Thank you, especially my big three in the major city and Kim Boyd for listening to me vent and being patient with the paperwork. Carol, thank you for having us. Amanda, our neighbor to the north, thank you for all that you've done. Appreciate your case study. I'll turn it back over to you, Carol.
Thank you. And those of you listening, can you imagine coming in and being an ombudsman, let alone a state ombudsman for just a few months before, boom, everything that we hold near and dear, being able to visit with residents or with anyone else for that matter, was put to a halt. Let me just mention that we have another webinar coming up on Friday, June the 18th on tips for identifying trauma, potential abuse, and supporting residents. Dr. Laura Muscata, Karen Jones, and Jane Brink are going to be the speakers, and you will be receiving more information on registration, but you can also do it from the link on this slide. And we're actually want to end with this statement. Lydia is a volunteer ombudsman in the state of Texas, And she was asked the question, what impact do you as an ombudsman have on residents' lives? She said, I am not sure. I bear witness for them. I sit by bedsides and hold their hands as they cry. I listen to them and let them know that I believe them. Too often, the testimonies of people in nursing homes are dismissed or disregarded. This harms a person's sense of worth and causes people to feel socially alienated or feel that they have experienced social death. It is an insidious form of ableism and injustice, one that is exploited to avoid accountability. And I think those words, they certainly resonate with me, and certainly several of our presenters today have talked about how important it is to be at the bedside, to be next to the resident, to listen to them. And as you guys are doing your complaint investigations and everything, I just encourage you to continue to listen to the residents, to do what they wish. And with that, I know we're right at the time. We've actually we actually had one question, and it looks like somebody answered it, but I will say that if you have a facility, the question was, how do you deal with facilities who are restricting visitation? They are only allowing one visit per month. I would say you should be talking to your state ombudsman, number one, and number two, the survey agencies should absolutely be telling facilities they cannot restrict visits to once a month. The life is slowly, day by day, getting better for all of us, and should be exponentially getting better for residents in long-term care facilities. I want to thank all of the speakers. I want to thank Katie for doing the background work on this webinar. Encourage you to reach out to the Resource Center if you have questions or are looking for any kind of resources. We'll mention to you that we have an app. If you go to the Apple Store and search for LTC Ombudsman Resource Center, you can get our app, and that way when you're in the home and you need to pull up the rule on what role you play, and if someone's trying to interfere with you, you can have that information. You can get right to the website and see a lot of the resources right then and there. So be sure and put that app on your phone. And with that, I want to thank you all for spending time today and for your work as advocates for residents. Goodbye, everyone.